So, welcome everybody. It's 7 o'clock, and I have a firm belief in my structure of starting on time and ending on time. And so, welcome to the Solid 2 uh, sessions that are set up for third and fourth year students across our learned nation. And tonight, as we start to get into our 2025 season, Annette Karen is a physician at Henry Ford Medical Center in Detroit. She is a specialist in geriatric care and palliative care. And one of the most important things that happens in our hospital rotations is how do we take care of patients in pain, and how do we do it appropriately and not just inappropriate. So Annette, I'm going to turn the world over to you and uh, next 25 minutes or so.
Okay, sure thing. Can you guys see my slides okay?
Yes.
Yes.
Good, 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 good. So welcome to all of you. Thanks to Dr. Good and all the ACUI staff and Dr. Roche for being here and putting together this program. So kudos to all you students that are taking time to do this, really putting in that extra effort. I think moves you from good student to rock star. So this is probably how I advanced my career the most, was kind of doing these extracurricular things. That's how I got involved in ACOI. So good for you. But so pain management is really probably at least a 3 hour talk. So to try to turn it into 20 minutes was difficult, but I thought, what are these students going out of their way to go above and beyond need to know to make you rock stars on rounds? So I practice geriatrics and palliative care. I still round in the hospital every day, do trauma consults on older adults, so little old ladies who break their hips, things like that. And do a lot of pain management, see a lot of really smart, good internists do a terrible job with pain management. So what I put together are kind of take home points, things I think you wouldn't have been introduced to in medical school. And again, things that I think will kind of change your future in terms of taking care of your patients. Just some tips for doing better pain management. And I don't care what field you're going to go into, you're going to take care of patients in pain. So be smart, educate yourself on it, go to whatever talks you can and learn about it. Don't be afraid of it. Don't think your doctors, your attendings at the bedside know exactly what they're doing, because they do not. They absolutely do not. We got no training on this in medical school. I mean, I'm older, but um, even now, some of the newer residents that I see got very little, and they learned from the bedside from docs who are doing it wrong. So just keep your mind open. I'm not telling you to speak up and correct your attendings, but just take a mark that you might have done it differently. So never talk about something without defining it. I think two most important points here is our patients are looking up the Random House Dictionary, and they want us to help treat mental and emotional suffering, not just bodily pain. And so we have to be aware of that. And I have kids that are your age, and they make me a better person every day, making me look at the whole person instead of just the patient. So I'm excited for your generation taking care of patients going forward, because you'll really look at the mental and emotional piece as well, better than we did. And then Margot McCaffrey's a nurse who did a lot of work in pain management. And the true way to practice is believe your patient. Again, really believe your patient. I can't stress that enough. There's so many patients who are in terrible pain, and they can't get opioids, they can't get treatment because they're just not believed. Even with cancer, it's an unbelievable crisis out there. So all different ways to classify pain. I put this out here. So today I'm giving you notes that are clinically important. So at the bedside, not, this isn't for a test, it's not for boards, but the way you're going to treat pain the most is looking at it acute versus chronic. So acute is an event that's usually sudden, usually resolves within days to weeks, and nociceptive. And we'll talk about what nociceptive means. Chronic is usually more than 3 months. Often they might have had an acute event, but you really wouldn't expect pain to linger past 3 months. Often unclear what caused it, often a neuropathic component. So just looking at your patient and think, is this acute or chronic? Acute on chronic is going to change your approach to pain management at the bedside. So types of pain. So you can see my slides don't all match. It's because I lecture a lot on pain management, have given lots of talks. And again, I just went through and pulled out the most clinically relevant slides. So these are a new classification of types of pain, new most specifically being the nociplastic. You won't hear your attendings talking about it. You might not even hear it in school, but nociceptive is kind of chronic, like we're used to broken bone, um, sickle cell disease, mechanical low back pain, neuropathic we've heard of, post zoster, trigeminal neuralgia, any post stroke, can all be neuropathic pain. So hopefully you've been exposed to those two. Nociplastic really has just come out in clinical practice in the last few years. It's really pain that arises from an altered nociceptive function. It's a chronic pain. An example is fibromyalgia, irritable bowel. This is relief for me just to think of all the patients I've taken care of in the last 30 years with fibromyalgia who suffer terribly, aren't believed that it's real, or all these pains that they just can't really find a source. But the patient is, I believe, the patient, and they're really in pain. So it's an important approach to pain. Again, I wouldn't expect you to document this in your record at the bedside. We don't use nociceptive as a clinical term often. It's usually musculoskeletal or GI pain, something like that, or we'd use. But neuropathic is a term we use often. You could remember they could be mixed. But the really most important part of this is nociplastic is not treated with opioids. And neuropathic, opioids are not first line treatment. They help, but they're not first line treatment. And so we'll talk about the opioid crisis and what it means for practice today. Those classifying of the pains will help you focus your pain and support your patient, focus the diagnosis and support your patient. So this is a busy picture, but I think important for you to look at. Pain is nociceptive, neuropathic. You can see this is an older slide, right? It doesn't bring in the newer classification of pain, but what's important is a social and spiritual. There's people are afraid they're going to lose work. How are they going to pay their bills if they're not working? How are they going to continue their intimacy with their partner if they have pain? There's a lot of fear, past disease experience come into it. This is why pain is so hard to treat. And again, your attendings, even if they're young, will not have had exposure to this education. So I really hope you take some take-home points from this and make this an important part of your practice whenever you're seeing a patient in pain. But they could have all of these factors that affect pain. I had met with a family yesterday for 2 hours. Their mom's been in the hospital 6 weeks. She has a disabling muscle disease. She's been intubated twice. She's edematous, only opens her eyes, otherwise minimally responsive. She's been on pressor. She's in restraints. And I met with them for 2 hours talking about goals of care, hospice, palliative care, her prognosis, and suffering. And the son actually said to me, I've been at the bedside every day for 6 weeks and I really haven't seen any suffering. And I thought to myself, oh my gosh, what am I doing here? I mean, they think because she's got a tube in her mouth. So how can she explain pain? But I mean, even families look and they see their mother. They don't see the edema and the swelling and the restraints. And, she can't speak. She can't, so we have to help patients understand that all the different levels of pain, because the patient might say, no, I don't have pain, but they have social, spiritual, or psychological distress. A lot of times I don't even use the word pain. I use discomfort or so assessment of pain. You guys are really good at this, right? Your PPQRST. I teach these slides. Some of these slides are from MSU COM because that's where I do some teaching and I lecture on pain there. And we always are good at asking about, what makes it better? What makes it worse? When did it start? Where is it? Does it radiate? Just make sure you document that on every pain, not just chest pain, abdominal pain, every pain. If you ever hear about a doc saying, I don't want to get reported to the pharmacy or the state board, it's because they're not documenting it well enough. Document this on every type of pain. Even my hospice nurses, when they call me, they'll say, can I increase the morphine? I'm like, wait a minute, where's the pain? What makes it better? What makes it worse? Does it radiate? If they had it before, you don't want to just go to opioids, even if they're on hospice. So tools out there, lots of different pain assessment tools. Make sure you're using a tool that's reproducible. So if your partners, nurses, or whatever are documenting it, you can truly document improvement or not. The 0 to 10 scale, I'm sure you're familiar with. Pain AD is in dementia patients. It's like a FACES scale. So you want to use some sort of consistent tool. Opioid misuse risk assessment tool. This is the future. This is one of your main take-home points that I hope you guys get. It's really moving very quickly to an expectation that anybody that we're treating with opioids, we're going to do a assessment for their opioid misuse. So it's a risk assessment tool. The most common is the ORT-OUD. You can look it up. It's I think 6-question tool. The point is we do this so that we know, not that we won't prescribe them opioids if they're at high risk for developing opioid use disorder, but so that we maybe prescribe them less pills, maybe bring them in more often, maybe quickly get them to interdisciplinary pain service, maybe do more topicals or adjuvant, or get them to OMM sooner, whatever, because if they're at high risk for developing opioid use disorder. Okay, that's the key to the future of pain management: screening for opioid use disorder, documenting it, and assessing that patient appropriately and treating them appropriately. I'll talk about buprenorphine. How many of you guys have heard of buprenorphine? So not too many. Probably a drug of the future, but we have an outpatient palliative medicine clinic. I work in a suburb of Detroit, but downtown Detroit, Henry Ford Hospital is like the hugest academic center. And their outpatient palliative care only uses buprenorphine, which is crazy to me. So too far the other way. It's a medication used to treat opioid use disorder, but also can treat chronic pain. But we have to use all our tools. So it's a really important topic that will be a part of your future for the rest of your career. So here's an example of the opioid risk, or there's a list of tools here. There's assessing for risk, characterizing misuse once treatment begins, and then other tools, the CAGE ad for screening for alcoholism, functional screening, all of that. All of these might be important. This is not essential. I'm just introducing you to all different tools out there. You don't have to recreate anything. And when you're in your residency in your clinics, you want to make sure if you're prescribing opioids, you're doing an opioid screening. This slide I love. This is from a talk I give nationally that's brand new. It's a talk I've been giving for about 7 years, but developed with a grant from the FDA by lots of leaders in the field. This is a brand new slide to it, and something I'm really excited about your generation to bring to the future. So 2 things I recommend that you do in the next year or so: watch the movie called Ben is Back. It's got Julia Roberts in it. Her son's addicted to opioids, and it focuses on how her 14-year-old kid got started on opioids and how it developed into opioid use disorder, and how the healthcare system creates barriers to getting treatment. So really a good movie. And then read Oprah's book, What Happened to You, because it's short. Even if you're not one of those I am not one of those touchy-feely kind of people, but it really is important understanding adverse childhood experiences. It's instead of saying this patient has this disease, what happened to this patient? People bring their entire history with them to deal with pain, and their family brings their entire relationship with that person to help them deal with an illness and pain. I can't tell you how many families on hospice that tell me to never give their mother morphine. I mean, crazy, crazy stuff I could tell you, but what happened to this patient? So any history of trauma, any other diagnoses all come into appropriate. So adverse childhood experiences should be really important part of your future in caring for patients, and important in pain management. Tim, can you do me a favor? I have like 5 minutes left. Just like give me a 5 or something,
Sure,
because
be
I
happy
don't have a
to.
clock on here. So pain assessment toolbox, again, this is a good website here. This is the full 2-hour lecture on pain that I give. That's the website for all the tools that are available. Again, not something that I expect you would use frequently in a lot of your patients, but it explains the pain AD. There's psychological tools for depression, anxiety, functional assessment, all things that you could use to assess your patient objectively. Okay. So how do we treat pain? By the mouth. This is the standards. It's old from 1990, but it's still the standard of care. Really, you want to use oral meds if you can. If it's chronic pain, you use something around the clock and something PRN for breakthrough. And if I'm using abbreviations you guys don't get, let me know. But by the ladder, we'll talk about what the ladder means and then relate pain to function. Really, really important to document in your record. So when you guys are rounding in the hospital and you have, I don't care what service you're on, you have a patient on pain meds, you want to put in your note how many PRN doses they use a day before. Look at the MAR, the medication administration record, if they're on PRNs, and you need to tell your attending the next day how many PRNs they needed. And then now they can get out of bed. How did it relate to their function? If they're still refusing to get out of bed, their pain's not well controlled. If this doc says we're not giving any more opioids or pain meds, then you have to start exploring non-pharmacologic interventions, psychosocial problems. If the doc says, if your attending says, they shouldn't need any more, this isn't usually that much pain, you got to start looking at other things. But in your notes, you'll be a rock star if you know how many PRNs they used in the last 24 hours and what their functional status is for treating their pain. And this is on outpatient, in the hospital, and then response to treatment, attention to detail. So this individual person, this is the step ladder. So you start on the bottom left with pain. You start with non-opioids and adjuvants, unless of course it's a fracture, you're going to go right to opioids, or an extreme pain. But you're going to start with non-opioids like acetaminophen, schedule acetaminophen. Look, and adjuvants mean things for like neuropathic pain, for depression, for bowel. We'll talk a little bit about that. And then when that doesn't work, you can go to your weaker opioid. And then if pain persists, you go to your more pure opioids like morphine, oxycodone, things like that. This is the standard of care for treating pain. Totally overwhelming. I'm going super fast because again, I just have a short time, but this is a good guideline. There's an updated one, I think from 2020 on initiating opioids, a CDC guideline, just a guideline, really, really worth reading. Again, for you guys, your guys are going to be ahead of your class and ahead of your peers on rotations and in your residency, just understanding how to prescribe opioids. You begin with immediate release PRN. Then once they're using a lot of PRNs, you schedule something around the clock and something for breakthrough. And this is for chronic pain. Okay. Opioid side effects. Your attendings may say, oh, they're 90, they can't have opioids because we're going to make them stop breathing. It's the most serious complication, but the most rare. And respiratory depression usually occurs in patients with opioid naive, which means they haven't been on any opioids and they got a big dose. The little old lady that breaks her hip, she's in the ED, someone gives her a milligram of Dilaudid and then they change shifts and she gets another milligram an hour later. That's going to cause respiratory depression. Okay. But it's not a reason not to give opioids. When I was in training, nobody with COPD or CHF got any opioids, period, no matter what was wrong with them, because we thought that we were going to kill them. Honestly, now morphine's part of the treatment, right, for heart failure and COPD. So we were wrong. So it's not, respiratory depression is rare, really rare, and usually again with bigger doses. The constipation, most common. If you're going to write for opioid, write for scheduled meds for bowels. These other things are common, but usually resolved within a few days. But just if you have serious side effects, that's where to report it. So I put this slide here just for you to understand why this is a crisis, why this is important. Opioid deaths have greatly increased even past heroin use. Most of it's from fentanyl-laced oxycodone or fentanyl-laced opioids, even fentanyl-laced heroin. But it's usually a synthetic fentanyl. It's not the pharmacologic prescribed fentanyl that's being abused, but it's still very scary. This is why a lot of docs are afraid to prescribe it. I want you to grow up and be a doc not afraid to prescribe opioids. Please, please. So mu receptors are important to understand. We had somebody when I was in training that said, Dilaudid's the only thing that works for me. We labeled them drug seeking. We told no, they got no Dilaudid, and we kicked them out of the hospital, right? So just knew nothing about pain management. Mu receptors, we all have mu receptors, different percentages. Somebody truly could respond better to one drug than another based on their mu receptor types. And there's some early studies about tests out there that you could say somebody might respond better to an opioid, one opioid versus another, but we're not using it in clinical practice as far as I'm aware. But because of incomplete cross tolerance, you have to be careful using different opioids on somebody, mixing opioids, moving from one opioid to another. So these mu receptors, again, if you really want to understand pain management, would be something important to prescribe. And as far as your boards, guys, it's none of this is going to be on your boards. This is pretty more advanced stuff and or clinical bedside stuff. Your boards still, unfortunately, are more academic than clinical. So this is examples of metabolism of opioids. Again, believe your patient, because now the standard of care is moving towards doing urine drug test in the clinic before you start somebody on opioids and randomly thereafter. This is important to know because if you might prescribe hydrocodone for somebody, which is Norco, but it can metabolize into hydromorphone, which is Dilaudid. So and morphine can metabolize into hydromorphone. So if you're going to do a urine drug test, make sure you know the last dose they took. Make sure they know what drugs you're prescribing. So just because of a negative urine drug test doesn't mean they're selling the drugs or they're taking something not prescribed. This is an equal analgesic dose table. You can download an app on your phone that for equal analgesic dosing that you type in what they're on and you type in what you want to move them to. Really, really, really important to understand this. I don't understand why this is so hard for docs in training to learn. This is just an example of one. And there's, again, I could talk for 20 minutes just on this table and its indications, but the most important thing is it goes across. So 10 milligrams of morphine injectable are equal to 30 milligrams oral. So 3-to-1. You'll be a rock star if your attending asks you that. I've never had a student know the answer ever when I ask them the ratio of IV to oral opioids, and that's common in most, 3-to-1. And then it goes down as well. So 10 of morphine is equal to 1.5 of hydromorphone, which is Dilaudid. So I will ask a student you'll never write for 10 milligrams IV of morphine probably in your entire career, but it's equal to 1.5 milligrams of Dilaudid, and you will write for 1 to 2 or 2 milligrams of Dilaudid hundreds of times in your career. It's because we don't understand the equal analgesic dosing and people are afraid of morphine, but just know the equal analgesic dosing. That's the biggest mistake I see docs make every single day. They have a patient who's on Dilaudid 25 mic patch, and then they prescribe 2 milligrams IV morphine for breakthrough pain. I mean, grossly underdosing. We're creating pseudo addiction. So naloxone, again, very exciting part of the future. You have a patient that you're worried about having significant side effects of opioids that you prescribe, you can prescribe naloxone with it, which is an anti-opioid. You can give quickly for you can tell your patients about it, their families about it. I carry one in my car. You can get it free at a lot of pharmacies. Some say it's expensive, but usually you can find a place to get it for free. The last tolerance, dependence, and addiction are the last couple slides. Addiction, remember, it's a lifestyle geared toward the acquisition of drug. Please never write in your chart that somebody is drug seeking. Never, ever, ever promise me that, because it's a terrible term. I had a nephew who died when he was 30 of metastatic cancer, and I helped him through 5 years of his life with a disease. And somebody wrote drug seeking, and it's a long story, but he had trouble getting pain meds the rest of his life because somebody put it in his chart. So addiction, he was not addicted. He was just had terrible disease and had trouble relating his symptoms. But addiction means they've lost control of their drug. Even when they get it, they don't feel better. Opioids, you can get physical dependent. So if you don't get it, you can go through withdrawal. It doesn't mean they're addicted. It means they're physically dependent. Really, really important to understand tolerance, physical dependence, and addiction. And then opioid use disorder, this is where buprenorphine, methadone, and naloxone are all drugs that we use to treat opioid use disorder, but you'll see buprenorphine used a lot more to treat pain. There used to be a waiver you needed to prescribe buprenorphine. That's why none of your docs will know how to prescribe it. The FDA got rid of the need for that waiver about 2 years ago. So if somebody says, I can't prescribe it, not true, not true. Really important to know this drug. This will be a huge part of your future. This is somebody that has high score on your opioid risk tool. You would use buprenorphine to treat their pain. But we also use it to treat opioid use disorder. But all docs should know how to prescribe this in the next 10 to 20 years. Methadone and naloxone also can be used to treat different pain and withdrawal. The PDMP is just every state has it except for 2, but they'll get it soon. You sign up for it, it's free. You can type in the patient's name and birth date, and you can see any controlled substances they had been prescribed in whatever time frame you put in. Amazing. Many have shared information with near states. So then you can know if the patient tells you, I haven't gotten prescriptions from anybody else, you can look it up and prove them wrong. So really great tool. You'll register for this probably in the first week of your residency. I know I'm almost out of time. So opioid disposal, you can look at these slides yourself. Something we're going to be obligated to teach our patients. Not absolutely something I never taught my patients before the last year or two, but we're obligated to teach how to dispose of them. If they're home, you take them out of the bottle, mix them with a noxious substance, put them in a plastic bag and throw them away. Really shouldn't put them down the toilet. Really shouldn't throw them away in the trash without anything with it. I'll let you look at these. Adjuvant means treating along with your direct pain management. So anti-inflammatories, muscle relaxants, neuropathic pain treatment, non-pharmacologic. Don't forget about non-pharmacologic interventions. Really, really important. Many don't have studies, but a lot of patients are going to believe Dr. Oz over us. So don't tell them, no, you can't have it, but just make sure they tell you so you can at least look up if it's interacting. Then check for depression, anxiety, insomnia, really important. If somebody threatens suicide, take it seriously. Okay. I put this in here as a reference for referrals and treatment centers for mental health. So the last 2 slides are just my day-to-day recommendations. So the most common mistakes: not understanding equal analgesic dosing, patient who can't swallow with dysphagia and prescribe oral meds. Huge mistake I see every single day. Multiple immediate release opioids. I regularly see patients on tramadol, Norco, and IV morphine. You should never, ever need more than one. I mean, you rarely need more than one short-acting, immediate release opioid, maybe one IV and one oral, but you should never need 2 oral immediate release. Simply never. Okay. Not scheduling bowel treatment. You make your patient constipated, they're never going to trust you again. You have to schedule a motility drug such as Sema when you prescribe opioids. Remember adjuvant treatment, and remember what's covered. The long-acting oxycodone now, Xtampa is the name. Most insurances don't cover it right away. So no, my partner uses it all the time, and then they don't get prior auth, and then they don't have it after they leave the hospital. So be careful about that. And then these are the things that before I walk away from a patient I see in pain, and I forgot to actually add in here non-pharmacologic treatments. So I consider their bowels before I leave when I do a consult. Do they have something for sleep? Are they sleeping? Are they depressed? Did I consider topical treatments? It's something that I didn't mention here, but really important topical treatments. Can anything be injected? Markedly reduce the need for oral meds because of injectables, and then non-pharmacologic treatment.
Annette, I'm going to let you know it's 7:30, so I'm
done.
Okay.
Sorry, I was going to try to be done at 7:20, but time for questions. So
yeah, we're gonna try to have questions at the end. Okay, so if you can just hang in there, we'll do that. Okay.
Okay.
All right. Very good. So I think these are excellent points, and please, students, please take note of some of these excellent components that she's talked about. Our next speaker is going to talk about research and the need for research as time goes on. Dr. Marty Birch is a electrophysiologist, cardiologist in Chicago, and he's also a past president of the ACOI. And Marty, there we go. Marty, where are you?
I'm here.
There you go. So turn the session over to you. Thank you.
Thank you. Can everybody see my slides?
Yes.
Okay, good. I'm just going to leave it on this sidebar just because it's easier. So tonight, and first of all, thanks, Bob, for inviting me to give this talk, and the ACOI for setting this up. This is a critical topic for students to take into account. Even though they're extremely busy and the rigors of medical school can be rather daunting, it's really important to start building at least a culture and a ability to perform scholarly activity, especially as you're interested in internal medicine programs. The ACGME and the Internal Medicine Center of the ACGME is specifically interested in research, and having a culture and reputation of research trumps the product for a time. And what I mean by that is that there's a certain pedigree system within the ACGME based on where you went to school that gives you a different perspective when you're interviewing. What trumps that then would be having extracurriculars such as research. And this does not have to be Nobel Peace Prize or Nobel research-wise research. This has to be something that just demonstrates that you're interested and have a culture within your mind and within your curriculum vitae that is significant so that they can put you into a pile with those pedigree students. IM residents have less required scholarly activity. IM fellows have clear requirement and expectations. So as you move up the train of training, you basically have to include this. And so the sooner that you become comfortable with it and understand how to do it, the easier it will be for you to get through your training at the most excellent level. And we're really talking about excellence here. People that perform research do better as physicians. The patients do better in terms of clinical outcomes. And so this is why it's an expectation within your training programs. These matters are very important, and they also lead to greater funding for positions for you to matriculate into. Funding is very broad. It can be across the government. It can be across industry. Comms can have funding. Hospitals have funding. Nonprofit foundations, NGOs, as they are called, can provide different funding sources for different ideas. Facebook, Meta now, they all provide foundational funding as a method to sort of build their culture within the research echelon. Google has a huge funding mechanism and actually give a lot of software and different avenues, especially with AI, in order to see what's the next best students that are out there performing this type of research, but also to get their algorithms out in play so that they can actually see how they work and see what's going to work from a marketing perspective. I already talked a little bit about why pursuing scholarly activity is important, but it really does link to global education, and it links global education and research to local care, which is really what you're all about. What you're basically looking at is a clinical practice in your future that's very local. And what I mean by that is that they would very much like to have me in Amsterdam to teach them how to do certain ablation techniques. Where it breaks down is that I don't speak Dutch. And so this really taught me that the clinical scenario is very local, and you should embrace that. I think it's really important as you move through your medical school that you have a plan going forward where you want to live somewhere that you want to build a practice, that you want to get to know the people, and you want to link that to the global education and research echelon, which you're already a part of in your comm. You just don't have it put in your face every single day. And I'll give you examples of that in the next few slides. What you really want to do with research is build your reputation. As my father always said, he's a lawyer, he said, you never have to advertise as a professional. All you have to do is do a great job and be a professional, and you will get work because it's needed. And there's not a single day that you'll have to advertise. So build your reputation and do it through scholarly activity, and then apply it to patient care. This is really an important slide. It's goes back to 2017. And this is important for you because I believe that the entire world in which you work in is going to be pressurized by this data-driven AI hype that's going around right now. And this was a great article because it really identified that the algorithms are already there. The problem is that the data is not there, and the algorithm's only as good as the teachers that teach the algorithm. And if you don't have solid data sets that are in technology-based solutions, you are never going to have a very good algorithm. The level of neural networks that are available today are staggering. They've had Watson out of IBM, and that's what this article is about. That's been available for probably 15 years. They tried to market it, but it didn't go anywhere because there was really no proof of concept, and the data had not been culled enough to teach the algorithm what they needed to do, because it's a huge investment for data. You, as you move forward in your career, are an algorithm. You are basically creating your local algorithm to clinical care. And I would say at this point, based on this article and based on the future of medicine, that you should all patent yourself right now in your persona and start to collect your data. Don't fill out these ridiculous EMR notes and not put it in a position that you can own your data and that you can own your management skills and everything that you come up with your patient pool, because it's hugely unique. The difference is that if I took 10,000 EKGs and I put them through an algorithm after I had adjudicated them, it would take the computer 2.3 minutes to actually come to the conclusion as to what I'm trying to teach it, where it took me many, many years to develop that 10,000 EKG algorithm in my mind. And so I think that it's really important to understand that we are a better algorithm because of our sentient nature and our ability to relate to patients and communicate. A computer is much faster at taking data, especially mathematical data, and making it into a very clear, sensical product or understanding. You are really much more important than a computer, and you should patent yourself immediately. And so I'll leave it at that. There's methods to do that. What constitutes scholarly activity today? Clinical science is going to be the key. It's 89% of clinical or of scholarly activity is produced across the world. These are first through case reports. There's retrospective chart review. There's prospective registries that you can become involved in and constantly call for data. And that's essentially the same as chart review. There's investigator-initiated research where you have an idea based on your clinical experiences that you want to answer or look into. And then there's large randomized clinical trials that are looking at specific questions and looking at new therapies to see how they compare against the standard therapy or placebo or both. So you can have the test intervention, you can have the standard intervention, you can have placebo. Then there's basic science, which is really bench lab results. There's a lot of basic science in the comms, not so much in the hospitals unless you're at a big academic center. You have to understand that in basic research, only 2% of the outcomes of basic science are actually translated to the clinical scenario. So that's a very low yield. There's a lot of investment from the NIH, and a lot of the big universities are run by PhD basic scientists. But to be honest with you, clinical science is the lion's share, and you can be a part of that through your entire training from medical school all the way into clinical care. Translational science was a big hot topic maybe 15, 20 years ago. It was really funded because they wanted to try to get a better yield out of basic science. But it's very difficult to move these clouds together because of time. And what translational means is that there's an entirely different language to basic science than there is to clinical science. And you're going to be much more involved in your training through clinical language as opposed to basic language. Unless you're completely interested in it and you want to go and discuss with your PhD physiology, biochemistry, microbiology colleagues and mentors, this is the lesser path for medical students. The simplest thing to do is look at quality and benchmarking, and to look at quality data collection on the physician-patient relationship, because that's really where you're working right now. And you can do these very simply by reaching out to mentors or people that you had a good relationship with during your externships, that you could actually get into this and do this on your free time or your extra time. This is extracurricular. But make it your project. These are things that come to mind as you're on rounds that might not be something that the attending physician has time for, but something that you can get involved in. And I'm sure that they would be as helpful to get that data for you. I already mentioned that the key to this is global research education, and the hands-on research experience has a big impact on your next level, which is residency selection. And you have to have some degree of experience with institutional review board or ethics committee preparation, submission, and management. And that just because it's a clinical trial doesn't mean that a student can't be involved in it. You just need to have the right mentor and somebody to be the principal investigator. A lot of the grunt work is done by professional research groups or people that have research analysts with research coordinators involved. And this allows for a high quality process. What I put in here usually is to really push for the students to do city training. Most of the comms have the ability for institutional training for research. That's online. You can get access through your institution. For instance, I have my entire group trained through Midwestern, and they have an institutional agreement with City that they pay for, and that's accessible by all of their students and all of their staff. And I would recommend that if you're interested in research, that you start here, because you learn all about the ins and outs of ethical research, high quality data collection, and really collecting source documentation for the research is absolutely essential. And you should learn about some of the instances where fraud was created, and there's a lot about that in the literature today since COVID and all these other aspects of peer review were somewhat corrupted. And they actually, in the whole process, as you can see, returns back to normal. There's corruption and everything, but in research, it's really important that we maintain ethical behavior. And I think for you, the first thing that you should do is do your city training and go through that, because it's the first thing I have my research fellows do every year. The key to research is really disputation. As they always say, there is no solid question that is answered to the negative. And so what I mean by that is that this is a constant disputation, and there's always room for improvement. And the first process of disputation is literature search. So you should be very facile, and you can have access through your libraries for literature search. So you have a specific problem and you want to dispute it, or you want to add to the science, which is always capable. There's never an end to science. Science is always in constant morphology. It's something that changes every single day, and it's worthy of challenging and disputing anybody's science. And I'll show you exactly how that happens worldwide, not so much in the United States, but in clinical fields outside the United States for sure. Culture continues with clinical science degrees and a PhD pathway. So you have access to that. It's not going to be in the United States, but you can do it outside the United States if you're so inclined to answer. So one of my classmates in med school did an entire PhD. We did rotating internships, so we actually had 3 years of clinical work that was sort of contiguous. That's not so much so common these days, but you went from a com to a rotating internship. He and I matriculated together through those 3 years. He had an entire PhD that was the first 12 papers that were describing MRI interpretation of breast cancer. So he took all the breast cancer biopsies from CCOM, and he brought them to Maastricht, and he had them organized in a lab. And he basically studied the tissue characteristics of weighted magnetic resonance, which is now clinically 40, 35 years later is now clinically commonplace. So this was a CCOM student. You can do this. You're no different than Tom Merchant. He's just like all of us. IM programs provide the clinical progressive field more so than most surgical and/or other clinical programs. IM fellowships drive even more progressive topics because it hones in to a specific field, and you become much more expert beyond just internal medicine. Internal medicine starts the stage. Fellowships, which are research-based, set the next progressive level that gives us unbelievable prevention capabilities that we didn't have in the 1980s. And you can see that the global clouds come together, and the organization strategy then becomes second nature, and it becomes broader, and it becomes bigger, and it becomes much more useful. And this happens first from your comm and your medical education through your internships, your fellowships, residencies. You become an instructor, you become a professor. I was lucky enough to move up to chief of cardiology at U of C. Key training with 60 EP fellows worldwide. Clinical research that started out as a case report, went to chart review, and then I became an industry trial investigator, trial partnerships, became investigator-initiated trial, research, randomized clinical trialist, worldwide principal investigator, chief medical officer, founder of startups, clinical science officer, and research education foundation that I started on my own. This was all a process that involves scholarly activity. And you can Google my publications. Basically, I just want to give you a firm example of how easy it is. So we did some animal surgical method. I hooked up with some Illinois Institute of Technology. Somebody said, "Oh, I'm a good guy to work with for this animal lab." These engineers came to me with an idea. We started a company and we started this whole process that was an utter failure. I mean, it was a total failure, but we were able to create this prototype subcutaneous cardiac arrest sensor, which actually was 20 years before its time. Actually, I think it's going to be something that you'll see in the next 10 years. We patented it. We did all this stuff. We created this whole microcircuit with 4 electrodes on it. We implanted it in all these dogs to survival, and then we basically let them run around, and we checked out the sensing and how it worked, and we induced ventricular fibrillation and stopped it, and we saw how it sensed ventricular fibrillation. And again, this failed, but everybody knew that I had done this research and that I published about 4 papers on it. And so then when they came to creating an entirely subcutaneous ICD, I was the only one that knew all of the sensing mechanisms in this region because I had already done all this work in animals. And we had created this whole library of EKGs in humans when I was implanting defibrillators in them. And so they came to me for this, and this actually became a huge success and has saved a lot of lives. And so you're looking at this as the final product, and you can see how similar it is. It's just a different device in the same area. And this is in humans now and is going through, it's been available now for over 12 years. And so this led to multiple clinical studies and this huge field of research that is in the beginning of it, and it's just every single person wants to cite my papers, and this gives me much more expertise and worldwide acclaim. And this is one of the papers that we published related to this early on, related to this device. Then what happens is you're invited to be in PhD defenses and perform the disputation because you're the world expert and this person is trying to get a PhD in that topic. And so they invite you to do this stuff in Amsterdam or across the world. And then this allows my students to get access to these students. And we start to look at different areas of deep learning. And we do this with the SICD. And this student, Eric Mercereau from CCOM, had this paper published in the European Society of Cardiology, and he presented this, and this is when he was a senior student, and the next year he was a orthopedic resident because of this work. I think that moved him right up into the pile of applicants that would be highly selected. So I'll stop there and take any questions and take any disputes. I welcome them.
Thank you, Marty. Anybody have any questions in the audience? You can either speak up or send a text message, chat message. Marty, I'm wondering, we every year at the ACOI, we have research presented, everything from case studies to actual research, both from a quality perspective. How would you say these students, as your third and fourth year students, where should they start? How can they get a decent either paper or a project completed and started?
Great question. I think that the main asks us to either a case report or to a original scientific research question. I think in the ACOI, they're looked at in a separate line. So that's great because I don't think you should be penalized for just doing a case report early on versus doing a original research. I think that what I've seen over the years is that the original research from the students has been outstanding, and it's been much more competitive than it had been in the prior 5 years. So that's a great thing to see, especially in osteopathic medical students. I think when you talk about the case reports, you really have to do a good literature search and understand where it fits into the overall lexicon of where you're standing with that particular case to make it really competitive. From a research standpoint, I think it's really important for you to do the research. I think if you do the research, then you're going to be much more capable of discussing it. And I think that it also is going to give you a better score when the judges come by, because they're going to realize that you have a good hold of this. And it doesn't mean that you have to be a biostatistician, but you have to employ or find somebody that's really good at biostats and have them teach you exactly how this fits into your clinical program and or research. So I think either one is great. And I think if you do it, it's really one step short. If you really get the bug when you do the case report, that's going to make you want to do clinical research.
So how would you get the data? I mean, in the EMR, yeah, it's everywhere. So
it's everywhere.
So describe how a student might take, I don't know, somebody with evaluation of chest pain in some way. It's highly sensitive troponins. I'm just throwing that out there. How would you take that information and turn it into some realistic and decent research project?
Yeah, so like right now, it's so different now than when Bob, you and I came up. I think that with Epic and or Cerner, these are the two major EMRs. You can go to your IT department and they will very much prefer that you do some queries into their Epic system, and it's set up that way to do that. And a lot of these institutions actually have this research kiosk in it, but they don't tell you about it. You don't know about it. And you can go do that right now. And like for instance, you can go in and say, I want to see how many patients came to our hospital in the last 10 years with fever and sepsis who have a pacemaker or a defibrillator in place, and then see what the outcome was with them. And because a lot of these patients don't get the correct therapy because they'll have endocarditis and or lead related infections, and it's underrepresented. And you can just do that as a quality research evaluation at your institution. And that's just one example. And it's the same thing with Bob's talking about, where you have these injury patients, and you can say, okay, so with ultrasensitive troponin levels, they come in and they're positive, and a lot of them just get forgotten about. And you could say, okay, we've got these patients come in with chest pain. They have abnormal troponin, high sensitivity troponin. They have a normal high sensitivity troponin. You can look and see, do they, what's the outcome? Because you have all that data because it's longitudinal through Care Everywhere, and you can see what the outcome is in those patients. Maybe in 6 months, they show up with a myocardial infarction or have a bypass surgery or some intervention, and you can just look at the outcomes from a different variable standpoint. That's all in these EMRs that nobody's really calling into because they're too busy putting data that's not maybe totally useful into the EMR every day for free.
So let me ask you about, I'm looking for other questions here, but let me ask you about IRBs, and when is an IRB required and when is it not?
So if you're doing chart review, retrospective chart review, like a quality program, like I just discussed, those two instances, you don't need an IRB for that. You can go do it wouldn't be a bad idea just to go to the IRB and get a sign off, what I call a waiver. So they'll say, oh yeah, you don't, because the main reason to go to an IRB is if you need an informed consent. If you're going to do anything prospective, looking forward towards outcomes, then you're going to have to get an IRB and an informed consent for the patient. And you may even, if you're doing partial retrospective and then you want to do prospective with a small group, you're going to have the IRB approve and informed consent to then use with the prospective subgroup that you looked at with the retrospective chart review.
So just briefly, tell me what an IRB, what is an IRB and why do we have to have it?
Institutional review boards are set up, they can be outside the institution or they can be in the institution. If you don't have a institutional IRB at your site, then you can use an outside one, like Western IRB is an outside, or Brainy is in New York. Western IRB is out west. If you go to them, most of them are recognized as, and they have 3 reviewers. They have 2 clinical reviewers or basic science reviewers, and then on the board is a layperson to always make sure that the ethics of the human research is within the guidelines that you would learn on city training. The next thing is that then they would look at the informed consent and make sure it's written at an 11-year-old interpretation level, and that it's something that somebody can actually understand and consent for. And then they would also verify whether or not you are an appropriate researcher based on your expertise.
Very good. And there's a question here for Annette. If you have a patient receiving pain medications from multiple different sources, how would you go about counseling that patient?
It would recommend just getting one prescriber because that's going to create a red flag in their PDMP. So I would encourage them to pick one person to prescribe their pain meds or have their docs talk to each other if at all possible.
Okay. There's the next question. How do you go about formulating a question for an original article? And I'd open that up to either one of you.
I think any question is good. I think the way to verify if the question is going to be additive is to do a literature search. And so you just have, and these are much easier now because you can just put keywords in and cross-reference them and you can get into a good literature search. I think that's the cornerstone of every question that you come up with. As far as, saying like what I'm doing now, which new devices and new therapies and things like that, that's something that I developed over 40 years. It's not something that you're going to jump right into. That starts with patents and intellectual property and things of that nature. I think that if you're looking at your level and as residents and fellows, that in order to do these questions, a lot of it's going to be retrospective just because of time and what you're actually doing. And if you are going to be at a place for more than 3 years, you could probably do a prospective study if you're really inclined and motivated. But it
I want
starts with a literature search.
to thank
And
both the speakers tonight. Thank you very much for your time. It's 8 o'clock, and again, start on time, end on time. Anybody that wants to hang, please do so. We have a few more questions, but please feel like if this is your time frame, you can leave. Uh, there's a question here, Annette, to you. Very common amongst pain medication patients or sickle cell patients who sometimes uh, require high doses, uh, but oftentimes they end up with admissions. So what's your take on the sickle cell patient, Annette? You want to put your camera on, that way you'll be visualized in the speaker.
okay.
There you go. Thank you.
Um, this is like a hot topic in pain management and very, very complex. With the newer, as we talked about, buprenorphine and things, those are good options. But usually I don't even see sickle cell patients because it's not really it's usually handled by the oncologist, and it's better with one person managing the pain, and they're going to follow them up outpatient oncology, hematology. So I recommend uh, it's very complex, but usually we've gone away from doing IV meds, using more buprenorphine, more methadone helps. They can be followed outpatient with that. It's inexpensive. Um, so I'm seeing a lot less inpatient sickle cell pain.
Okay, so perhaps we're doing a better job in the ambulatory world with sickle cell as we learn.
Mhm.
Yeah, I
Uh,
hate to keep you, Bob, but I wanted to mention something about the research. Whenever a student spends a month with me on the service, I make them do a quality improvement project within that month. So I will, the first day we round, we'll pick a patient, and I, especially because I do geriatrics and older adult patient, and I will pick something in the room or their chart, and I'll say, "Does this bother you?" My biggest pet peeve is like an order for oral care. What does that mean? So pick 5 patients that have that order, talk to their nurse, and see what it means, and then you can develop just a 5 patient uh, problem in the hospital, the SCDs, for whether they're wearing them, if there's an order, sitters, restraints, all of those. So pick just some issue on a patient you're seeing and start with a quality improvement project. You don't need IRB approval. You can do
right.
5, 10, 15. So just an idea.
Yep, I require that as well, that they do some baseline research with my internal medicine rotations, and we're just publishing a paper now based upon pre-diabetes care and multiple cohorts that we've had over the last 3 years. So they have the data, and we're able to work through that data. Anyways, it's things that I think attendings want to see students doing.
Yeah, I
Marty,
agree.
you look like you're going to say something. So
Yeah, I agree. I think that it really is a distinguishing feature that's ubiquitously available. And I think that you just have to start the process of developing a method. And so you just heard from Annette and Bob that, in their daily rounds, they're pushing the concept of researching and putting together cohorts as small as 5 patients. We've had papers, except like I have a paper right now that's in final review with 20 patients looking at a new project, new process of defibrillation. And it's of interest because it's pushing forward an improvement and maybe decreasing the cost of defibrillation therapy. These are two things that are not necessarily important to most of the researchers in the world, but for the average patient, it's really important. And so you don't have to have a 300 patient randomized clinical trial. You can do it with 5 patients as long as you're coming to a conclusion that improves the outcome.
Yeah, every day we come up with questions we don't know the answers to.
Oh yeah, it's endless. There's nothing solved in medical science.
And what we thought we knew, we don't know.
Correct. Yeah. Never feel comfortable. That's the one thing I always tell my students. If you feel comfortable, then you're not working hard enough. If you're not feeling a little bit uncomfortable every time you're doing something, then you're not really helping the patient out. You should always push the envelope and try to challenge yourself. It's really important.
Well, again, thank you to both speakers tonight. I appreciate your expertise for the students, and this is all on video, so that it will be live, it will be streamed, and oftentimes these programs are picked up multiple times. So thank you very much to everyone. Wish you a good night and happy January.